by Dr. Ajit Mullasari, sir. It's a 4-piece OCT image acquisition, capture the perfect. So Dr. Netley also said you should have a good image for interpretation. So just doing imaging will not help, and I think Ajit sir will enlighten us with how to do the imaging.
Thank you, Rupali, and thank you very much, Wincars, for calling me once again for this meeting. And I think me and Mamas have been here for every meeting of Wincars in the last few months. So let me just go to a simple talk on what are the simple P's that you need for a good picture. If you don't get a good picture, you can't read the picture. So the first P is to purge your catheter. Now, if you look at this whole thing, you can see that the catheter has to be dipped. You have to have a good 3 drips in the catheter so that the catheter is clean. If you have any air or dye inside that, you are not going to get a good picture. So purge the catheter with a media, flush media, 3 drips. Connect the catheter to the dock. And remember that you can inject dye either through an injector or manually. I prefer an injector because it's continuous, the flow. And the left coronary can take 4 cc's per second with a total of 14 cc. The right can take 3 cc's per second to a total of 12. Large vessels like grafts can take up to 20, again 4 cc's, and the manual injection, the maximum is 16 cc's in a 20 cc syringe. The key is adequate clearance time and not volume on automatic pullback. And that's very, very important when you take a good picture. The next thing, when I'll show you the picture next, select the pullback length and image acquisition mode. And this is very important before you start taking the picture. I like manual pullback in certain scenarios when it's small vessels, very tight stenosis where sometimes the catheter won't move back on automatic pullback, or extremely large vessels when I need to have, and when you're dealing with sometimes in the ostium. So these are the areas where you should use a manual pullback. The catheter has an imaging core. Inside, there's a lens here, there's an imaging sheath, and there is a side port where the drip happens. Now, when you take a pullback length, you need to know what are you looking for. Do you want high resolution or do you want length? And this determines whether you take a 54 millimeter or a 75 millimeter, and you have to adjust your frames per second accordingly. For example, if you want a high resolution image, we would use a 54 millimeter 10 frames per millimeter at 3 seconds. While if you have a long acquisition, when you want a bigger length to balloon, you will take a 75 millimeters, 5 frames per millimeter with a 2.1 second pullback. So this is important before you decide what you want to do. Now, the first part is outside. Once you've checked that the catheter is working, you have to then decide inside the body to find the region of interest. So after you calibrate the catheter outside, you got the eye on the catheter, you monorail the catheter quietly, and then to the region of interest is what you have to do. Now if you look at this, there's a distal marker on the OCT catheter, there's a proximal catheter marker, and there's a lens marker. And this is very important for you to do. The lens starts away from the distal marker, so please keep the lens marker at least a few millimeters, 5 millimeters at least beyond the lesion. Otherwise you'll miss the lesion when you're trying to pull the OCT back. Number 2, engage the guide catheter, and you should not have side holes. That's very important, especially when you're doing an OCT. Remember, the arteries are always responsive to nitroglycerin, and make it a habit, whether you're doing OCT or IVUS, that you use liberal nitroglycerin so that you get the right sizing. Now, the enable live image and inject flush media to deliver nitroglycerin ensure an adequate. So there is a live image. I'll show you the picture in the next. That should be done to deliver nitroglycerin and ensure adequate blood. Do not waste contrast because we want less contrast to be used. As such, we are using contrast for OCT. We can use saline in some patients, but please try to less use contrast for the dye issues. And purge the catheter nicely. This minimizes signal damping. So let's look at, here's a lesion, and we have a catheter here. So, your lens is here, your markers are about 20, you can see one marker here, you can see one marker there, and you can see the other marker here. So this is where the lens is just proximal to the second marker. So there is two markers with 20 millimeters and the lens is before that, and that's very important for us to understand. So proximal marker, lens marker, and a distal marker, that's what you need to do. And your region of interest has to be in between the lens marker and the proximal marker. That's what you need to look at. So if somebody can help me to just click on that video, because I can't do that from here. Can you click on that video? Okay, so this is how the OCT guide is. So the nurse is helping us to flush the catheter. Once the catheter is fully flushed out and clear, she opens the cover. And it has to be done in an aseptic way so that you don't get into trouble with infective issues. So you hand it over to your tech or a physician assistant who's helping you, and he pulls back the catheter into the plastic module. As you can see, it's very important that you put the male and the female dock in the correct way so that it doesn't get broken. And you wipe your catheter next to activate the hydrophilic coating. It's very important you wipe it so that it's very important to do that. Connect your syringe filled with 100 cc contrast in your injector. Purge your catheter, as I said, drape the dock using a septic technique and connect the catheter. The sterile operator is to secure the dock sleeve septically. Ensure that the dust cover on the dock is opened and secure. Instruct the sterile operator to place their hands in the inner fold of the cover. And that's the common mistake. When you're docking the catheter, you become unsterile. It's very important that you know how to do it. And I would suggest that all nurses are trained outside the lab to do this. Clamp as necessary to maintain the sterility. Now this is the manual contrast. You should have at least 20 ml syringes. You don't need to do it hard. You need to have a continuous injection. It should be 14 ml and 100% clean contrast. You should not mix it. These are the injectors. You have various types of injectors. I use my normal injector, which I use for my cath lab work. So this is the dock, and you can see the green connector, and that has to be docked correctly. Do not touch the inner fiber topics when you do that. And that's very important. Can you play the video, please, once more? So this is how the nurse would help you. Just put it out. These are very simple steps, and most of the problem starts if you don't do these technical and then you get a fault. You've injected 20 cc dye and then you don't get a picture. Next, please. And then you position your catheter lens distal to the lesion. Purge the catheter lumen via the side port. There's a side port on the catheter. We use 3 cc syringe. And be very clear that the dye is clearing through in the whole thing. Puff the manifold to verify the catheter injection and blood clearing, and then pull back the image. So in this process, once the catheter is placed correctly, there are 3 things that you need to do. Either you control the dock or your technician controls the dock, and you need to do a few things. You start your cine, you start injecting your contrast, and then enable the catheter. So otherwise, what will happen is you will not get the full picture when you're doing. So it's important to position, that's the first P, purge the catheter, puff the manifold, and then do the pullback. These are the 4 Ps that we need to know in the whole catheter. And these are the Dragonfly Optis catheter. I think most of us are used to it, so I'm not going to go into it. I think everybody should know the screens. They should know there are three things: pullback types, trigger, and acquired angio. And you need to know that. And these are all can be pulled down on the screen and used for what you want to do. So if you get a picture like this, it's not a good picture. There's blood swelling there. On the left side, you can see that. Clearly there's blood there. And you need to have a clean picture which is purged here to get a nice picture. In a live view, I always use a puff of contrast to evaluate the clarity and the guide catheter. If your guide catheter is out, you will not get a good picture. So be clear that you get an optimal clearance. And these are the auto-enable of the dock system or the auto-calibrate on the console if your technician is doing it. When the trigger is set to manual, I think press live view for the dock or the sterile or live and step off the cine pedal, view on the console and auto-calibrate. So I think these are the steps that you need to do for the manual. And in the interest of time, I'll just show you quickly what it does. This is how you purge it. Then you press after you press your enable, you press it again, and then you start your pullback, and by the time you're already on cine and your dye injects. Automatic is important when most of the cases, I'm not going to go through it. Again, the similar thing, you go to live view, purge, enable auto calibrate, and then enable the auto pullback. When you remove the catheter, it's also important you don't damage it. So it's important to press the disconnect system and then disconnect the catheter in a counterclockwise loop. There's an unload button on the top, as you can see there. So sometimes, why do we press live view after we have advanced? Because the catheter is spinning at 20 frames and we don't want to damage the catheter when it's moving. So press the live view only after the catheter has passed the lesions, otherwise you'll damage the catheter. What's the main reason for injecting a puff of contrast in live view? To visualize the lumen clears the blood and the guide catheter is engaged. If the catheter doesn't pull back, what is the common issue? You set it on manual and you want it in automatic. Change your screen from manual to automatic. What are the guiding catheters? 6 French, no side holes, correct curve to engage the vessel properly, and you can use whatever you want, automatic or manual, according to the lesion. So, ladies and gentlemen, these are the simple 4 Ps. So, position your catheter, purge the machine, prepare the whole system, and then do the pullback. Otherwise, you'll get a bad picture, and that will help you not to do anything but repeat the procedure again.
Thank you, sir, for such a detailed discussion.